So let's begin with the divisions of pharynx. The first one is the nasopharynx, which is the uppermost part of pharynx. As we have already seen, it is also called as the epipharynx. Now let's see the boundaries and extensions of nasopharynx. Superiorly it extends from the base of skull. Inferiorly it extends till the hard palate. The floor is formed by soft palate, which we can see here. It is deficient posteriorly, which is called the nasopharyngeal isthmus, through which nasopharynx communicates with oropharynx.
Anteriorly, nasopharynx is bound by posterior nasal apertures and posterior ends of nasal turbinates. Posteriorly, as we can see, it lies opposite the C1 vertebrae and its overlying fascias. Next, moving on to the most important one, the lateral wall of nasopharynx. Around 1.25 centimeters posterior to the inferior turbinate, we can see an opening. This is the pharyngeal opening of the Astrakhan tube. Surrounding this is an area of elevation which is called the torus tuberis. Do you remember the tubal tonsils which are located here? Yes, these are the subepithelial lymphatic masses located within the torus tuberis. Now let's travel a bit posterior, and behind the torus tuberis, we are seeing this recess which is called the fossa of Rosenmuller. The clinical significance of this site is, it is the most common site of origin of the nasopharyngeal carcinoma. Now let's see something else. Traveling 1 centimeter posterior to middle turbinate is another opening, which is called the sphenopalatine foramen. What is the clinical significance of this one? It is the most common site of origin of an angiofibroma. Here we can also see the adenoids. These are located in between the roof and the posterior wall of nasopharynx. These increase in size up to an age of 6 years and start regressing soon after puberty. What is the clinical significance of the tubal tonsils? Well, any infection of these will result in an inflammation of the torus tuberis. This can lead to the Astrakhan tube closure. Well, that's all about the nasopharynx. Let's see the oropharynx. Superiorly it extends from the hard palate, and inferiorly it extends till the hyoid bone. Posteriorly lies the C2 and the upper half of C3 vertebra. Next, let's see the anterior boundaries, of course the base of tongue, and right behind which lies the lingual tonsils and also the vallecula, which are the cup-shaped depressions present between the base of tongue and epiglottis. Next, let's see what is present in the lateral wall. All this which you can see here is the posterior pharyngeal wall. So here laterally around them is the lateral wall. So we have the tonsillar pillars, which are 2 in number. The anterior and the posterior tonsillar pillar. The anterior pillar is formed by the palatoglossus, while the posterior pillar is formed by the palatopharyngeus. Both of them originate at the palate, but the palatoglossus attaches to the tongue while the palatopharyngeus attaches to the pharynx. In between both these pillars, there exists a triangular fossa, called the tonsillar fossa, within which we have our palatine tonsil. Let's see if we can identify these structures in this photo. This is the base of the tongue, and this wall lying behind is the posterior pharyngeal wall. Here are our anterior and posterior pillars, and in between them is lying a mass which is the palatine tonsil. This is the same palatine tonsil but from the other side. Here we can already make out the 2 pillars, the anterior and the posterior of the 2 sides. The palatopharyngeus in the posterior pillar gives off some circular fibers posteriorly. Now can you name this area that's being highlighted? Yes, it's the posterior pharyngeal wall. Now try to recollect which external muscle will be present in this wall at the level of oropharynx. Yes, it's the superior constrictor. So the circular fibers of our palatopharyngeus fuse with the existing superior constrictor fibers to form a raised ridge, which is called the Passavant ridge. Now try imagining the soft palate lying above. During swallowing and speech, the soft palate contracts, which makes it come in contact with the Passavant ridge. Why does this need to happen? We have the nasopharyngeal isthmus, connecting the nasopharynx with the oropharynx. This is the opening which the soft palate coming in contact with the Passavant ridge closes. So the nasopharynx is cut off from the oropharynx. We have two clinical conditions here, one being an insufficiency of this can result in velar-palatine insufficiency, and the second being obstruction caused due to the hyperactivity of this ridge or soft palate. Now let's see about the last one, the hypopharynx. It extends superiorly from the hyoid bone to the lower border of cricoid inferiorly. Posteriorly it is bounded by the lower half of C3, C4, C5 and C6 vertebrae. What lies anterior to this? Technically it is the larynx. However, the cricoid cartilage results in a bulge, hence altering the shape of the hypopharynx. This shaded area right behind the bulge of cricoid is the postcricoid region. And this pink shaded part is something we already know about: the posterior pharyngeal wall. Now lateral to the postcricoid, the space here is the pyriform fossa. So these are the three major parts of hypopharynx. Let's see the same in this picture. Here the highlighted area with a bulge is the postcricoid region, and these gaps lateral to this are the pyriform fossas. Let's know a little more about the pyriform fossa. It lies on either sides of larynx. See here in this picture, considering this as larynx, you can make out that the pyriform fossa does actually lie on either sides of larynx. Laterally it is bounded by thyrohyoid membrane, and medially bounded by aryepiglottic folds. Just imagine the food passing from above into this cross-section we drew. Does the food we eat enter the laterally lying pyriform fossas? Yes, it does. It allows for the lateral passage of food. It is also a site where the foreign bodies might lodge. Let's also see the clinical significance of this fossa. Do you remember the internal laryngeal nerve? If yes, then you must also be remembering how it passes in between the middle and the inferior constrictor. We also know that these two are located at the level of hypopharynx. So from where exactly does the internal laryngeal nerve enter into hypopharynx? It enters into the pyriform fossa and lies submucosally. So how is this implicated? In surgery, where one needs to be careful while operating this region, also when one can administer the local anesthesia to this nerve, and the most important one being the referred pain. In cases of carcinoma of the pyriform fossa, one feels the referred pain at the ear. Now let's see about the postcricoid region. This lies in between the upper and the lower cricoid laminae. The clinical significance of this is, it is the most common site of carcinoma in females with Plummer-Vinson syndrome. Let's talk about one last clinical point before we wrap this up. So we know that hypopharyngeal muscles when contract, the area dilates and the food passes down. Here we have our upper esophageal sphincter, and for food to pass down into esophagus from the pharynx, this sphincter needs to relax. Let's see a case where the hypopharyngeal muscles do contract but the sphincter doesn't relax. This is what results in the hypopharyngeal diverticulum. That's all about the anatomy of the pharynx.